Secondary amenorrhea. Dr. Hana Alani. Is the absence or abnormal cessation of the menses. Amenorrhea. Is the absence or abnormal cessation of the menses. Physiological. Amenorrhea. Pathological. Amenorrhea. Control of menstrual cycle. Hypothalamus. Pituitary. Endocrine. Ovarian. Outflow tract. Axis. Classification of amenorrhea. Prepuberty. Pregnancy-related. Menopause. Primary. Secondary. Amenorrhea. Pathological amenorrhea. A patient is diagnosed with primary amenorrhea if she has not reached menarche by age 16 with normal secondary sexual characteristics. Secondary amenorrhea if established menses have ceased for longer than 6 months without any physiological reasons. Secondary amenorrhea. Secondary amenorrhea is the absence of menstrual periods for 6 months in a woman who had previously been regular. Secondary amenorrhea, physiological. The most common cause of secondary amenorrhea in reproductive age women is pregnancy, and this should always be excluded by physical exam and laboratory testing for the pregnancy hormone, HCG. Secondary amenorrhea, etiology. Endocrine. Hypothalamus pituitary. Pituitary tumor. Sheehan's syndrome. Hypothalamic dysfunction. Hypothyroidism. Cushing's. Adrenal tumor. Ovarian tumor. Androgen. Ovarian. Premature ovarian failure. Cause. Surgical removal. Asherman's syndrome. Hysterectomy. Outflow tract. Secondary amenorrhea/oligomenorrhea, etiology. Most common etiologies. Ovarian disease -40%. Hypothalamic dysfunction -35%. Pituitary disease -19%. Uterine disease -5%. Other -1%. Secondary amenorrhea/oligomenorrhea, etiology. Pregnancy. Thyroid disease. Hyperprolactinemia. Prolactinoma. Breastfeeding, breast stimulation. Medication, i.e. antipsychotics, antidepressants. Hypergonadotropic hypogonadism. Postmenopausal ovarian failure. Premature ovarian failure. Hypogonadotropic hypogonadism. Functional hypothalamic amenorrhea, i.e. anorexia or bulimia nervosa. SNES tumor, i.e. craniopharyngioma. Sheehan's syndrome. Chronic illness. Normogonadotropic. Outflow tract obstruction, i.e. Asherman's syndrome, cervical stenosis. Hyperandrogenic anovulation, i.e. PCOS, Cushing's disease, TA. Secondary amenorrhea, etiology. Hypothalamic causes. Hypothalamic dysfunction is a common cause, 30%. It is more often seen as a result of stress, weight loss, and eating disorders. It may be due to tumor, infarction, thrombosis or inflammation. Secondary amenorrhea, etiology. Pituitary causes. Pituitary failure. It is usually the acquired type as the result of trauma, treatment of pituitary tumor or infarction after massive blood loss, Sheehan's syndrome. Pituitary tumor hyperprolactinemia which cause secondary amenorrhea. Secondary amenorrhea, etiology. Endocrine causes. Thyroid disorder and Cushing's disease interfere with the normal functioning of the hypothalamic pituitary, ovarian axis present with amenorrhea. High level of thyroxine inhibit FSH release. Androgen, secreting tumors of the ovaries cause secondary amenorrhea. Secondary amenorrhea, etiology. Anatomical causes. Usually due to previous surgery. Commonest example. 1. Hysterectomy. 2. Endometrial ablation. 3. Asherman's syndrome, damage to the endometrium with adhesion formation. 4. Stenosis of the cervix following cone biopsy. 1. Uterine defect Asherman's syndrome. This is intrauterine synecdoche E. Withdrawal bleeding after hormonal test is negative. History of DNC after delivery or termination of pregnancy. Other cause TB or schistosomiasis. Normal ovulatory cycle and premenstrual symptoms. Patients with Asherman's syndrome may be evaluated by HSG and transvaginal US. Treatment. Hysteroscopic treatment with excision of synecdoche E. Maintaining of separation of uterine walls by insertion of a large inner tract such as a Lippis loop. The result of treatment are often disappointing in terms of subsequent fertility. Secondary amenorrhea, etiology. Premature ovarian failure. Premature ovarian failure occurs in about 1% before the age of 40. Premature ovarian failure may be due to 1. Chemotherapy and radiotherapy. 2. Autoimmune disease following viral infection. 3. Following surgery for conditions such as endometriosis. Treatment of premature ovarian failure. Ovarian failure before 40 years. Ovarian failure before 30 years may be due to chromosomal disorders. Karyotyping is done to check for mosaicism. Some cells have Y chromosome. Gonadectomy is indicated to prevent malignant transformation. Other causes of premature ovarian failure. Ovarian injury from surgery, radiation or chemotherapy, galactosemia and autoimmunity. When premature ovarian failure is secondary to autoimmunity, other endocrine organs could be affected. Investigations. FPS for diabetes. Free thyroxine, TSH for hypothyroidism. Serum calcium for hypoparathyroidism. Fasting morning cortisol. Treatment of premature ovarian failure by hormone therapy, estrogen and progesterone. Secondary amenorrhea, etiology. Drugs causing hyperprolactinemia. Hyperprolactinemia accounts for 20% of cases of amenorrhea. Prolactin inhibits HNA-H release from the hypothalamus. Drugs may cause hyperprolactinemia. 3. Amenorrhea with hyperprolactinemia. Galactorrhea is the most frequently observed abnormalities associated with hyperprolactinemia. Hyperprolactinemia that is severe or associated with menstrual disturbances or galactorrhea should be confirmed by a second test. TSH should be tested for hypothyroidism. If clinically significant hyperprolactinemia is not explained by hypothyroidism or drug use, a CT or MRI scan of cell latersika should be performed. Drugs that may cause hyperprolactinemia includes 1. Tranquilizers, 2. Antidepressants, 3. Antihypertensives, 4. Narcotics, 5. Metoclopramide. Mechanisms that produce prolactin. 1. Normally dopamine suppresses prolactin production. If a mass compresses the stalk of the pituitary, the dopamine feedback pathway is interrupted and it can no longer inhibit prolactin levels. Also, HNA-H will not be able to pass through and there will be LH and FSH. If there is prolactin and LH and FSH, there may be E2, estradiol, levels. Consider hormone replacement therapy. 2. Hyperprolactinemia may also be caused by psychoactive drugs which suppress dopamine. Even so, you will still see FSH and LH levels. 3. Prolactin-secreting adenomas produce excess prolactin levels. 2 types of prolactin-secreting adenomas. Microadenomas versus macroadenomas. Less than 10 mm, greater than 10 mm diagnosed on MRI. Important to do associated with visual symptoms. Very benign and headaches. Treat symptoms only. Amenorrhea must be treated. Follow-up MRIs every 1 to 2 years to check surgical treatment. Bromocriptine agonist. may shrink adenoma for additional growth. Radiation works well but may cause panhypopituitarism. Treatment of hyperprolactinemia. Dopamine agonist therapy, cabergoline, bromocriptine, most common. This should induce ovulation and shrink the adenoma. With drug-induced hyperprolactinemia, bromocriptine may counter the effects of the antidepressant medications. If it is a macroadenoma, transsphenoidal resection may be done. This will result in resumption of ovulation for 40% of patients. Only 10 to 50% will have a long-term cure with the surgery. Response to radiation can be very slow. If a patient has a microadenoma or other causes of hyperprolactinemia, birth control pills may be used to bring on regular periods and to correct the galactorrhea. If a woman wants to try and have a baby, you can try ovulation induction. Goals of treatment: regulate menses, prevent endometrial hyperplasia, induce ovulation for pregnancy, improve hirsutism, excessive body hair in a masculine pattern of distribution due to hereditary or hormonal factors. Secondary amenorrhea, etiology. Polycystic ovarian syndrome, PCOS. PCOS accounts for 90% of cases of oligoamenorrhea, also known as Stein-Leventhal syndrome. The etiology is probably related to insulin resistance, with a failure of normal follicular development and ovulation. The classical picture: amenorrhea, obese, subinfertility and hirsutism. The assessment: history, examination, investigations. Assessment. The most common cause of secondary amenorrhea in reproductive age women is pregnancy, and this should always be excluded by physical exam and laboratory testing for the pregnancy hormone, HCG. Assessment. History. A good history can reveal the etiologic diagnosis in up to 85% of cases of amenorrhea. Clinical assessment, history. Ask about menstrual cycle, age of menarche and previous menstrual history. Previous pregnancies, severe PPH, Sheehan syndrome. Weight change, a large amount of weight loss, anorexia nervosa. Hot flashes, decreased libido, premature menopause. Certain medications. Contraception. Associate symptoms: Cushing's disease, hypothyroidism. Previous gynecological surgery. Chronic illness. Clinical assessment, examination. Check for body mass index, BMI, weight loss related amenorrhea. Blood pressure elevated in Cushing and PCOS. Androgen excess, hirsutism, PCOS, viralization, tumor. Secondary sexual characteristic. Breast examination may reveal galactorrhea. Abdominal, hematomera, and pelvic masses, ovarian tumor. Inspection of genitalia, cervical stenosis. If the history and physical exam are suggestive of a certain etiology. Clinical assessment, investigations. If the history and physical exam are suggestive of a certain etiology, the workup can sometimes be more directed. Clinical assessment, investigations. Some patients will not demonstrate any obvious etiology for their amenorrhea on history and physical examination. These patients can be worked up in a logical manner using a stepwise approach. Investigating secondary amenorrhea. The most common cause of secondary amenorrhea in reproductive age women is pregnancy, and this should always be excluded by physical exam and laboratory testing for the pregnancy hormone, HCG. Investigating secondary amenorrhea. Once pregnancy has been excluded. Progesterone challenge test. TSH, thyroid stimulating hormone. FSH, LH. Prolactin level. Secondary amenorrhea/oligomenorrhea, evaluation. Progesterone challenge test. Medroxyprogesterone acetate 10 mg daily for 10 days. If withdrawal bleed occurs, not outflow tract obstruction. If no withdrawal bleed occurs, Estrogen/progesterone challenge test. Estrogen/progesterone challenge test. Oral conjugated estrogen 0.625 to 2.5 mg daily for 35 days. Medroxyprogesterone acetate 10 mg daily for 26 to 35 days. If no withdrawal bleed occurs, endometrial scarring. Hysterosalpingogram or hysteroscopy to evaluate endometrial cavity. Investigating secondary amenorrhea. Negative pregnancy test. FSH, LH and thyroid function test. Progesterone challenge test. Withdrawal. Bleeding. No withdrawal. Bleeding. Hyperestrogenic. Compromised outflow tract. Anovulation. Positive EP. Challenge test. Negative EP. Challenge test. FSH normal plus high LH PCOS. High prolactin pituitary tumor. Normal or low FSH. Very high FSH. Normal FSH. Ovarian failure. Asherman syndrome. HSG or hysteroscopy. Hypothalamic pituitary failure. Secondary amenorrhea/oligomenorrhea. Evaluation. Evaluation of hyperandrogenism. Symptoms: hirsutism, acne, alopecia, masculinization, and viralization. Differential diagnosis. Adrenal disorders: atypical congenital adrenal hyperplasia, CAH, Cushing's syndrome, adrenal neoplasm. Ovarian disorders, PCOS, ovarian neoplasms. Lab: testosterone, DHEAS, 17-alpha-hydroxyprogesterone. Hormone level. Indication: testosterone less than 200 nanograms/dl. PCOS greater than 200 nanograms/dl. Evaluate for adrenal or ovarian tumor. DHEAS less than 700 nanograms/dl. Greater than 700 nanograms/dl. 17-alpha-hydroxyprogesterone greater than 4 nanograms per milliliter. Consider ACT stimulation test to diagnose SCAR, ovarian failure, premature menopause. Secondary amenorrhea. Ovarian failure, premature menopause. Chromosomal anomalies. Autoimmune disease. If the woman is under 30, a karyotype should be performed to rule out any mosaicism involving a Y chromosome. It is prudent to screen for thyroid, parathyroid, and adrenal dysfunction. If a Y chromosome is found, the gonads should be surgically excised. Laboratory evidence of autoimmune phenomenon is much more prevalent than clinically significant disease. Hypothalamic pituitary failure. Secondary amenorrhea. Hypothalamic pituitary failure. Patients who do not bleed after the progestin challenge, but do bleed after estrogen/progestin and have normal or low FSH and LH levels. Investigating secondary amenorrhea. Investigations. Diagnosis. Site of disorder. FSH, LH and estradiol, low. Hypothalamic failure. Weight-related amenorrhea. Hypothalamus. Prolactin, high. FSH, LH and estradiol, low. FSH, LH and estrogen, low. Pituitary adenoma. Sheehan syndrome. Pituitary. TSH, raised, T4, low or N. Hypothyroidism. Endocrine. FSH, LH, high, E2, low. FSH, normal, LH, high. Premature menopause. PCOS. Ovary. EPCT-negative. HSG, hysteroscopy. Asherman syndrome. Mullerian tract. Treatment of amenorrhea. The need for treatment depends on underlying causes, need for regular periods, trying to conceive, fertility, Need for contraception. Treatment of amenorrhea. Trying to conceive. The prognosis for women with confirmed ovarian failure is poor. Anovulation responds well with ovulation induction treatment. Cause ovulation may resume with weight reduction, fertility drugs. Use of gonadotrophins or ovarian drilling. Hyperprolactinemia respond to treatment with dopamine agonist. Hypothalamic dysfunction maintenance of normal weight and change of lifestyle. Asherman syndrome breaking down adhesion plus insertient. Treatment of amenorrhea. Want regular period. The use of 1. Combine oral contraceptive. 2. HRT. Need contraception. Confirmed ovarian failure will not require contraception. Women requiring contraception. Oral contraceptives are. Method of choice. Amenorrhea/oligomenorrhea, management. Diagnosis. Management. Ovarian insufficiency. Premature ovarian failure. Postmenopausal ovarian failure. Hormone replacement therapy, HRT. Congenital anatomic lesions. Surgical correction. Presence of Y chromosome, IAIS. Gonadectomy. Gonadal dysgenesis, i.e. Turner syndrome. Estrogen plus progestin, growth hormone. IVF, if pregnancy desired. Hyperprolactinemia. Dopamine agonist, bromocriptine, cabergoline. Functional hypothalamic amenorrhea. Increase caloric intake greater than energy expenditure. Hypothalamic or pituitary dysfunction. Non-reversible. OCPS, pulsatile GnRH or exogenous gonadotropins. SNES tumor. Craniopharyngioma. Prolactinoma. Surgical resection. Microadenoma, less than 10 mm, dopamine agonist. Macroadenoma, greater than 10 mm, transsphenoidal resection. Cause. OCPS, weight loss, and metformin. Asherman syndrome. Hysteroscopic lysis of adhesions. Causes of primary amenorrhea only. Treatment goals of amenorrhea and oligomenorrhea include prevention of complications such as osteoporosis, endometrial hyperplasia and heart disease, preservation of fertility, and in primary amenorrhea, progression of normal pubertal development.